Hey everybody, it's your classmate David Raposa here to present my process improvement idea. So as you know, the first step in any quality improvement project is deciding what quality needs to be assessed. What am I interested in? And for my quality improvement project, I've decided to assess the quality of medication administration, specifically in the world of anesthesia. And once we've decided what is good quality and bad quality, we have to decide what the improvement will be. And in my QA project, I feel like the improvement that I would like to make is reducing the amount of administration errors in the world of anesthesia. So just to sum that up, putting it all together, for my QI project, I want to improve the quality of medication administration by reducing medication administration errors in anesthesia. So we've all read Joshi, several chapters at least at this point, and we're familiar with the PDSA or the PDCA model, and some of you may be familiar with the API model, which just tags on 3 additional questions prior to diving into this cycle. What are we trying to accomplish? How will we know what change is an improvement? What change can we make that will result in an improvement? And in this presentation, I hope to at least tackle that first question. What am I trying to accomplish with this process improvement? So anesthesia is a lot of things to a lot of people, but in my mind, pharmacology is number one. If you read any anesthesia textbook, they're going to tell you we have the power over analgesia, anxiolysis, amnesia, akinesis, autonomic control. That is what we do, and we use drugs to do that. So let me set the stage to elucidate this problem a little bit. So as you know, we have this arsenal of elixirs at our disposal. We are the rock stars of the operating room. We blow kisses and gases and splashes of propofol from the head of the bed for thousands of our adoring patients. These are powerful drugs, man. But seriously, given their powerful nature, we have the responsibility to use them wisely. And we do. We use them safely and we try, but sometimes we fail. So we need to find out. I need to find out how to minimize and mitigate my personal potential for having an error, having a medication error. So again, let's paint this picture. Say you're sailing through your various riffs that you've created with your anesthesia art. And when all of a sudden your patient decides to traverse a rockier route than you intended them to, and you have 5 seconds to open your anesthesia medication card, choose the right medication, and save the day. We do it every day, right? So go. Did you find the medication you were looking for? Obviously, I'm trying to prove a point here. When you're in a hurry, your human factors are magnified. And the literature I've read about cognitive load theory basically says your brain doesn't work as well when it's under increased stress and it has increased input. That's anesthesia, right? When everything's hitting the fan and you need to grab it and grab the right medication. It's possible to overload your brain's computational power and we make mistakes. So what's the solution? In my mind, it's keep it simple, shorty. Uh, and this medication drawer is not simple. It's fraught with potential for making a medication administration error. Brian brought this point up in one of his discussion board posts where he said, phenylephrine and Zofran looks almost the same. They have the same colored cap. And we know that the color coding scheme is no scheme. There's no rhyme or reason to it. Drug companies aren't bound by any safety regulations in their drug design. It's basically left up to graphic designers and what looks the best for product selling. But I want you to look for the Versed in that same drawer that we looked at in the previous slide. But I'll give you a clue first. So the Versed is the one with the blue cap. Or maybe it's the one with the white cap, or the yellow, or the red, or the green, or the gray, or the purple. Does that make it clear for you? All right, grab the Versed. Again, trying to prove a point here. There's a problem, and this problem leads to medication administration errors. Is it that drawer? Is it that drawer? Is it that drawer? Is it that drawer? And the more you use this drawer, the more familiar you'll get. But it's obviously not the best solution. My other question is, how often do we make these medication errors? And from my reading so far, I don't know that we have a good answer to that question. How often? I did find a study that specifically looked at the difference between self-report and actual medication errors. And I don't think that our self-report is reliable whatsoever. So this study, performed by Flynn et al., a little bit back 2002, and this wasn't in the world of anesthesia, this was on the medical floor. They directly observed 2,500 medication administrations. And one of those medication administrations was reported as a medication error, one of 2,500. About 1% of them were charted as medication administration errors, but the observers who were observing the RNs give the medications actually felt that 18% of those were given in error. And I'm not talking about wrong drug, but it could be wrong time, late time. You see the difference between self-report, though, and actual medication administration errors. So where do I look for my project? Can I look in Quantros? Can I rely on Epic? And I don't think that I can. They might have give me an idea as to what it may look like at Sacred Heart, but I think that I have to look at the literature to really paint the picture of what the problem is. And I did a mini lit review. I did a PubMed search with simple key phrases like medication administration errors in anesthesia, and I found dozens of articles. And ever since To Err is Human came out, there have been hundreds of studies about medication safety and studies. This is just a screenshot from my beloved database that you all know I love, Mendeley. And just to give you an idea of how many articles there are out there that show that this is something being studied. Medical errors related to look-alike and sound-alike drugs, medications and anesthesia, medication errors in anesthesia review. So you're getting my point here. And part of my overall project, part 2, I will be looking at that literature to kind of paint the picture as to what I could potentially do to solve the problem. So, as I told you, we may feel like we're rock stars, but we're not rock stars. Here's a study that was actually specifically performed in the world of anesthesia. Nanji et al., and it's a recent study in 2015, showed that for every 20 medications that we administer, the 20th one is given in error. So 1 in 20 medications that we give is given in error. And there's a broad range in that definition. It's not, again, giving the wrong drug, but 1 in 20 of our medication administrations is given in error. The other thing that they found was I said 1 in 20 is a medication error, but it's 1 in 60. So every third mistake that you make will result in an adverse drug event, an ADE. So really it's this 60th administration that causes patient harm. But still, 1 in 60 is not a good record. We obviously need some help to improve our patient safety. Bringing this back to the To Err is Human report by the Institute of Medication that said that 98,000 deaths per year are caused by us, by providers. How many of those are we responsible for in anesthesia? So my QI goals, I'd like to align them with the Institute of Medicine's goals. We read about these as well in Joshi and other articles that we read. The 6 main Institute of Medicine goals: to be safe, effective, efficient, timely, patient-centered, equitable. I think they all align with reducing medication errors, which is my QI goal. So what is the setting? I'd like to limit it specifically to Providence Sacred Heart Medical Center, which this is kind of one of our basic ORs you see here, and I am at the head of the bed there providing anesthesia. So that is where my quality improvement, or my process improvement will take place. And who needs to be involved? Who are the players that have to sit at the table? Well, pharmacy, clinical engineering, anesthesia, Epic, anybody who's involved with capital, so any solution that I may propose may need some money, and of course, the DNAP program. These are the players that have to work together to find a solution and to actually implement a solution that will reduce medication administration errors. And again, I just like to define safety. It's freedom from accidental injury. I didn't define that. It was in Joshi. So my project defined will be freedom from accidental anesthesia. So that is my process improvement project. Hopefully you get an idea at least of where I'm going with it. These are the references that I referred to in the presentation itself. And so far, these are the references that I found that I will use in my mini lit review. Thank you for listening.